We're thankful to Dr. NAMRATA for chipping in. I think Dr. Rajesh probably forgot about this meeting, and she is going to be telling us about DALK in eyes, keratoconus, and the techniques and challenges. On to you, Doctor.
So, can you hear me, Chitra?
Yes, yes.
Okay, so this might be a little, it's a little change, but I would be talking to you about deep anterior lamellar keratoplasty in cases of keratoconus. And ectasias could be primary or iatrogenic, as has been talked about, and DAL can be done in any of these cases, especially when they become more severe and more advanced cases of keratoconus. And these are the guidelines which have been given when you can do deep anterior lamellar keratoplasty, and this is generally given in advanced cases of keratoconus when the corneal thickness is less than 380 microns. Patients are contact lens intolerant, and of course when it becomes very advanced you have to do penetrating keratoplasty. Otherwise you can even get away with the automated lamellar therapeutic keratoplasty in these cases. So I will just skip this part of ALTK because we are only talking about DALK. The advantages of DALK is that maximal removal of the diseased tissue is possible. The Descemet's membrane is a smooth graft and virtually there is no interface at all. And like I said, it can not only be done for keratoconus, but also can be done for other endothelial sparing diseases. Now, there are various techniques like the big bubble technique of Anwar, which is the gold standard, the hydrodelamination technique, layer by layer, viscoelastic technique assisted by Melles, and air assisted technique by the Arkela et al. And contraindications are, although we are still doing it in healed eye drops, but these are contraindications whenever there is any endothelial involvement. Now, we do prefer to do under general anesthesia, although peribulbar anesthesia can be used for these cases, and topical anesthesia should never be used. And donor tissue with poor endothelial quality can be used. Avoid tissue with a heavy arcus, and a backup good quality tissue should always be available. Now, this is just to show the technique by Melles, which is, I think, the safest technique. Air bubble is put inside the anterior chamber. A 400 microns groove is made. Lamellar dissection is then done from limbus to limbus, following which the viscoelastic is injected. So because you're doing a lamellar dissection, you are not near the Descemet's membrane. I mean, you're not exactly above the Descemet's membrane, but near the Descemet's membrane. So then viscoelastic is injected, and then sutures are placed onto the incision which had been made earlier. And then following which trephination is then done, and the anterior part of 400 microns is removed. And so you do reach up to the near Descemet's membrane level, and after excising this, a full thickness donor cornea is taken, which is bereaved of the endothelium, and then is sutured tightly with 10-0 monofilament nylon sutures. Then the host graft disparity is generally kept less, about 0.25. Some people even like to keep the same size graft. Now, with the advent of Dua's layer, the way we look at DALK has completely changed. So Dua's layer is nothing but it is the condensation of the stromal keratocytes as is shown here. And if you have a bubble that is instilled above Dua's layer, it is type 1 big bubble. And this will have a rough surface because there's Dua's layer which is staring at you. And if it goes beyond this Dua's layer, then you have a type 2 big bubble. And it's going to be absolutely smooth and glistening because Dua's layer is not there at all. So it is a smooth surface. Now, there are two types of big bubbles. This is the big bubble type 1, in which the partial thickness trephination is done, and this is followed by the air bubble, which is instilled at a depth of about 70%. In fact, it goes into the pre-Descemet's membrane compartment, and this can be appreciated on the intraop OCT microscope. The Descemet's membrane has fallen back. This is, of course, an inverted image. And as you give a nick in the overlying stromal layers, the air bubble egresses out in a live show, and so does the Descemet's membrane move on the intraop OCT microscope, which actually see in the surgeon's eyepiece, and you know that you are in the correct plane. And then viscoelastic is then instilled. So again, this would move behind with the viscoelastic just like a kangaroo's pouch, and this is just playing on the Descemet's membrane, and this is the bare Descemet's membrane which is looking at you, and this is then sutured with 10-0 monofilament nylon sutures. So the type 1 big bubble went from the center to the periphery. Type 2 big bubble goes from the periphery towards the center, which you can see here. It has come right up to here. And this is again 70% trephination, which has been done. This is followed by the AC paracentesis. And just watch this bubble. It will expand a little bit as you do AC paracentesis. And when you do AC paracentesis, the Descemet's membrane kind of falls back. And so when you're giving a nick in the overlying stromal layers, again, this will come out, and this comes out very quickly now. So watch for it. As soon as you do this, the Descemet's membrane is again moving upwards. Then again, this is viscoelastic is instilled, and again, this will fall back, and then dissection is done over this. Just to show cases of DALC in cases of keratoconus, the results are pretty good with a perforation rate of 4 to about 13%, and successful big bubble is obtained in almost more than 80% of the cases. Now, in cases of healed hydrops, also I said you can do DALC, and you need not do it with the IOCT. But what happens is that if the areas of the healed hydrops is a little paracentral, as can be seen here, you can do a layer by layer dissection. And this is done after doing trephination, giving a nick. And as you do dissection layer by layer, just as you come to the area of the healed hydrops, go a little anterior. So you go a little anterior, and this scarred area moves little paracentral, which can be seen here. But in the post-operative period, the remodeling would occur, and this is just 52 microns. It looks pretty clear because the scarred area has been removed, and very little what is left has moved to the paracentral area. When you have keratoconus with pellucid marginal degeneration, then you can do a tuck-in lamellar keratoplasty. And here, basically, a flange is made all around. I think I'm not going to talk about it because I'm sure Dr. Radhika is going to show this. So we then come to penetrating keratoplasty whenever there is full thickness scar for which you have no choice left but to do a full thickness penetrating keratoplasty in these cases. A bit about a new type of keratoplasty which we are doing with the bioengineered corneas, and that is intrastromal keratoplasty. And this is not deep anterior lamellar keratoplasty, but it is done in cases of advanced keratoconus. So a pocket is made with the help of femtosecond laser. This pocket is then opened up, and we have now bioengineered or biosynthetic cornea. So this looks pretty much like the contact lens. This is folded. This is obtained from recombinant technology, and this is then unfolded inside. So it reinforces the corneal thickness, and then you don't need sutures in this. You can just put a bandage contact lens, and this is then in the post-operative period, these patients do quite well. So thank you very much for your kind attention, and thank you, Chitra.
Yeah, that was a wonderful talk, and we really needed this talk because this session is so incomplete without it, and thanks for being so supportive at this point. But just a question, do you think that manual dissection cases as against big bubble would have definitely poorer visual outcomes in these eyes?
So the manual big bubble, whenever you come up to the Descemet's membrane, then of course the quality of vision is much better as compared to the pre-descemetic DALC. But having said this, in terms of the visual acuity qualitatively, I think there is not too much of a difference. For instance, they may be 6/6 both ways, but perhaps the contrast would be better with descemetic DALC than with the pre-descemetic DALC.
Dr. Radhika?
Yeah, so that was a wonderful talk, Dr. Namrata. So like you yourself mentioned, probably there are two aims to doing a DALC. One is to remove as much disease tissue as possible. And like you beautifully showed in your surgery, the interface is very pristine. In fact, there's no interface at all when you leave back just the Descemet's membrane. So the quality of vision is very good. But the question that I want to ask you is that now is the day and age of tuck-in stromal lenticules for keratoconus. As also you showed the bioengineered synthetic tissue, which can do the same job. So here again, in fact, the issue of interface becomes double. There are two interfaces now, and we are not even removing the diseased tissue of the keratoconus. So the question that I'm asking is that then would it be also equally prudent to revert back to just lamellar keratoplasties, which are not full thickness, so that the learning surgeon can learn it easier and we get the desired result also, even though we are not at Descemet level, even though we are not removing the entire diseased tissue?
You're quite right. I think I completely agree with you, because we move back, not move back, but everybody is trying to move back to intrastromal keratoplasty, which can be done with a donor cornea or can be done with a biosynthetic, with the synthetic material that I showed you. The only problem is that when you do it with a donor cornea, just like a DSA graft thins over a period of time, likewise, the donor corneal lenticule would also thin over a period of time. But that will not happen with the synthetic cornea. But yes, the problem of double interfaces continues to be there. And the advantage of a desmetic DALC is that there is a interface, but that's not visible at all.
Thank you.
Thank you. Thank you, Dr. Namrata.